Hello, everyone. My name is Kane Daniela. I'm a faculty member and the medical director at Cone Family Medicine Center. Today, we'll review the transitions of care process. Learning objective. For this presentation, we'll define transitions of care, identify the risk factors and preventive measures for ineffective transitions of care, and lastly, we'll review the key components of transitions of care, including handout and discharge process. Now, let's define transitions of care. Transitions of care refers to the movement of patient or their health information from one care setting to another as their condition changes. The movement can be within the hospital setting, in other words, from the intensive care unit to regular floor, or from regular floor to the cardiac unit. It could also be a transfer across the healthcare settings, in other words, from outpatient to inpatient settings, or from an urgent care setting to an inpatient setting, or from inpatient care settings to an outpatient care setting. So, why do we care? Why are we having this conversation, and why is this important topic to discuss? Ineffective transitions of care increase the risk of medical errors, hospital readmission, and poor patient and provider satisfaction. Of note, more than 50% of medication errors are due to poor transitions of care, which itself increases readmission rate. Readmission is defined as rehospitalization within 30 days of previous hospital discharge. Readmission, as we know, is not cheap. It costs the health institution about $15 to $20 billion annually. Increased readmission will subsequently lead to both patient and provider dissatisfaction. What are the causes of ineffective transitions of care? The biggest one is communication breakdown. When there is a lack of standardized handoff or discharge process, miscommunication can occur, leading to ineffective transitions of care. Patient education breakdown is also an important cause of ineffective transitions of care. Patients may not understand some medical jargons or abbreviations used in healthcare settings, leading to confusion and poor transitions of care. For example, QWK should be written clearly as every week to avoid confusion. Poor transitions of care can also occur when clinician lacks accountability and do not take ownership of patient care. For example, a primary care provider may refuse to refill medication prescription that was provided to their patient during urgent care or hospital visit. For the next few minutes, we'll go over a few cases. Case number one, an 80-year-old male with extensive past medical history was admitted for stroke-like symptoms in 2022. A CTA head and neck shows 10 mm anterior communicated aneurysm. His assessment and plan indicates that patient has anterior communicated aneurysm. Hence, interventional radiologist was consulted for cerebral arteriogram and embolization. Plavix and aspirin were subsequently initiated, and physical therapy, occupational and speech therapies were consulted. The patient had an uneventful procedure during this hospitalization and was deemed stable and ready for discharge to the nursing facility by the neurosurgeon and interventional radiology team. Subsequently, he was appropriately handed off to the hospitalist group, who later realized that the patient should have been with a different healthcare team due to bounce back status. An unassigned patient who was recently admitted to a particular care team unit will bounce back to the same team if readmitted within 30 days of their initial discharge. The hospitalist group consulted the appropriate team and conducted a telephone handoff. Not only was a telephone handoff conducted, patient encounter note was also created by the hospitalist team, documenting the handoff between the hospitalist and the family medicine team. The next day, the family medicine team reached out to the interventional radiology team for sign out to assume patient care, which is the right thing to do. However, they were advised that the patient has been discharged directly to the nursing facility from the neurology floor, hence transition to family medicine care is now required. Of note, all the communication at this point was through the secure chat portal, which is a HIPAA compliant real time messaging tool built directly into the EHR, allowing clinicians and staff to communicate securely about patient care. Unfortunately, secure chat messages do not automatically file into patient's chart, and all communication will be lost in a few days. On day three post-operation, family medicine team noticed that patient had not been yet discharged despite initial discharge plans. Hence, they again reached out to the interventional radiology team to reinitiate transitions of care via telephone call. The family medicine team was again advised by the interventional radiology team that despite the delay in discharge, the patient is still being transferred directly to the nursing home. Unfortunately, again, this encounter was not documented in patient's record. Remember, if it's not documented, it did not happen. Somehow there was a break in communication where neither the interventional radiology team nor the family medicine team evaluated the patient in over 24 hours. Hence, the hospital leadership reached out to the family medicine team for patient abandonment. Remember, the only documentation on file regarding transitions of care was by the hospitalists who affirmed that transition of care to family medicine team has been done. So technically, the patient care belongs to family medicine team. Using this fishbone diagram, let us analyze the breakdown in communication in this case. The main problem here is patient abandonment. The people involved in the case include the interventional radiologist, hospitalist, and family medicine team. We can argue that there was inadequate communication among all the team members involved in patient care. We can also say that there was a lack of accountability, where everyone involved in patient care assumed that they had no responsibility for the patient. For the process, there was a lack of standardized handoff process with some communication via telephone and others through secure chat messaging, which is not an effective means of communication for documentation accuracy. Regarding management, there was a health insurance approval issue that delayed transitions of care in this case. Please spend additional time using the fishbone diagram to evaluate this case regarding what could have been done better to prevent an ineffective transitions of care. Case number two. A 45-year-old female with a history of hypertension, prediabetes, alcohol abuse was admitted in 2021 due to change in her mental status. She had recently been hospitalized for COVID-19, treated with remdesivir and Decadron. Her stay was complicated by medication-induced hyperglycemia at the time, for which she was started on insulin injection. Her discharge medication at that time included hydrochlorothiazide 25 milligrams daily, Novolog 2 units 3 times daily, Decadron 6 milligrams daily for 3 days, and Tylenol as needed. The question is, what is the potential cause of her rehospitalization, and how could this rehospitalization have been prevented? If your answer to the first question is hypoglycemia, you're correct. The patient was discharged home with insulin to be used while on Decadron. However, there was no clear documentation in the discharge summary that Novolog was needed to be discontinued when the patient completed their Decadron treatment. This rehospitalization could have been prevented with effective communication and medication reconciliation at discharge. Now, let's talk about key steps in ensuring medication safety. Number one, appropriate prescription and risk assessment. This is important before prescribing any medication. Consider the side effects and contraindication for that particular patient. Number two, review previous medication and assess to see if there's any cross interaction with a new prescription that's going to be ordered. Thirdly, ensure that accurate mode of administration is documented. Don't mix up the routes of administration. For example, boric acid should be administered per vagina and if taken orally can lead to death. Number four, communication is very important. Review medication with patient and their family and communicate any changes that were made during hospitalization. Lastly, medication reconciliation is very crucial and it should occur at every care transition from the day of admission through discharge. Now, I'll quickly go over the 7 elements of effective transitions of care. Number one, leadership support. Each institution should strive to provide resources to support transitions of care, including space, staffing, equipment, and transitions of care in services or orientation, such as this. Number two, multidisciplinary communication among team members is important and should continue from the patient's hospitalization through discharge. Thirdly, risk assessment of individual patient is important. Some patients have a higher risk for readmission or medication error due to their complex medical condition. Once these risks are identified, create a plan to mitigate the risk. For example, an action plan such as care coordination structure can be implemented, and this will involve case management, social worker, physical therapy, and pharmacy to provide support to patients even outside of the inpatient setting. Number four, comprehensive discharge planning, and this should begin on the day of admission and continue through discharge. This includes medication reconciliation, discharge site identification. In other words, is the patient going home or to the nursing home? Would they need durable medical equipment to support them at discharge? Also, create a follow up plan. Number five, medication reconciliation. This is a key component of effective transitions of care to mitigate medication errors. Six, patient and family engagement in healthcare is an important aspect of transitions of care. Help patients understand the nature of their diseases and involve them in decision-making process. Lastly, the transfer of information through effective handoff and discharge process, which is crucial again in ensuring effective transitions of care. Now let us talk about handoff process. Handoff is an interactive process of transferring patient-specific information from one caregiver to another to ensure continuity of care and patient safety. According to the Joint Commission National Patient Safety Goal, handoff must be an interactive communication. It must contain updated and accurate information. There must be limited interruption and there must be an opportunity to review any relevant historical data. There are various tools out there that can be used to complete handoff process and they include HiPass, SBA, and SignUp. HiPass is one of the most important tools or most commonly used, I would say, and Hi stands for illness severity. In other words, is the patient stable or unstable? P stands for patient summary, what happened from the day of admission till now. A stands for action item. S stands for situation awareness. In other words, having a contingency plan for every situation change. An example of that would be if a patient develops cough, please obtain chest x-ray. And the last S stands for synthesis by the receiver, where the receiver reads back the information provided. Here is a practical example of HiPass you can use to practice in your leisure time. This YouTube video demonstrates an effective HiPass as a handoff tool. Please enter the link directly into your web browser to assess and review the content. Here is another training video to highlight Andoff pitfall. And again, please type the link into your browser to review. Finally, a quick review of the discharge process. While handoff is the transfer of a patient-specific information, the discharge process is the transfer of patient themselves from one healthcare setting to another. So one is transferring information, the other is transferring the patient themselves. The elements of discharge process include discharge planning, which is, as previously mentioned, which starts from the day of admission till the day of discharge. Medication reconciliation, which also starts from the day of admission till discharge. Discharge summary, which is the mode of communication between the hospital and the aftercare provider. This should be completed ideally within 24 to 48 hours of discharge and should include admission summary, patient care outcome, and follow-up action plan. And lastly, patient instruction about the care provided. This should include all information of the things done in the hospital, lab, test result, and all of this information should be provided to the patient verbally and also in printed format. Timely hospital follow-up is a key component of discharge planning and should be completed within 7 to 14 days of discharge. Take-home point. Transitions of care is a transfer of patient or patient-specific information from one healthcare setting to another as their condition changes. Handoff is the transfer of patient information, while discharge process is the transfer of patient from one healthcare setting to another. And an effective transition of care process may reduce medical error, medication error, and healthcare costs. Here are my references. Thank you for watching.